Okay, so let's go ahead and call the meeting to order. It's 4:02 on Thursday, February 11th. My apologies. I don't have a keeper to keep me on task this afternoon, so I got off and did something else. Forgot it was 4 o'clock. But Mr. Ferris, could you please call the roll?
Certainly. John Surface.
Here.
Bruce Peters.
Here.
Supervisor Maggard is here.
Here.
Dr. Kansen.
Here.
Chief Martinezson. Sheriff Youngblood.
Here.
Kathy Prout.
Yes, here.
Dr. Lyon.
Here.
Leslie Wilmer.
Here.
We have a quorum.
Very good. Thank you, Mr. Ferris. We're going to forego the flag salute because we're not in the same room with a flag handy, so we'll forego that today. First, we're going to deal with our consent agenda this afternoon. All items on consent are listed with a CA preceding the item on our agenda and are considered by division staff to be routine and non-controversial. Consent items can be considered first and approved in one motion, so we're going to do that now and kind of clear those off of our table. So the first consent item is item number 5. The next is under item 10, items A through D. Do any members of the MCAB board have question or comment about any items that are on consent? Don't see anybody. Does anybody from the public have any comment to us about items on consent? Mr. Ferris, do you see any indication that anyone is interested in commenting from the public?
I do not, sir.
Okay, so if somebody would make a motion to approve, that'd be great. Just give us your name. It'd be easy for the person recording. Give your name and just say motion. That would be great.
Dr. Lyon, so moved.
Thank you, Dr. Lyon. Is there a second?
Youngblood.
Very good. Thank you, Sheriff. We have a motion and a second. Mr. Ferris, can you call the roll?
Yes, sir. John Surface.
Yes.
Bruce Peters.
Yes.
Supervisor Maggard.
Yes.
Dr. Kansen.
Yes.
Sheriff Youngblood.
Yes.
Kathy Prout.
Yes.
Dr. Lyon.
Yes.
And Leslie Wilmer.
Yes.
Passes all ayes, sir.
Thank you very much. Thanks, everyone. We have item number 6 on our agenda today is a subcommittee report by Jeff Ferris. It's regarding the ambulance patient offload times task force. So, Mr. Ferris, could you proceed with giving us that report?
Sure. It's going to be a quick one. Because of COVID and the issues going on, I wasn't able to get on it as quickly as I'd wanted to. I do, however, I have sent out a request, and I have a full task force membership. So in the next week or so, I will be sending out the first initial meeting request to discuss. I have representatives from all hospitals in Kern County, all the major hospitals, and ambulance providers that will be taking part in the task force. So I'm very excited. That's a good thing. That ends my report.
Very good. Thank you, Mr. Ferris. Anybody have any questions for him? I don't see anybody indicating that. Is there anybody from the public who would like to make a comment about that report? Okay, then would somebody give us a motion, please, to receive and file?
Peters, motion.
Thank you.
Lyon, second.
Very good. Thank you. We have a motion to second. Mr. Ferris, could you please call the roll on that vote?
Yes, sir. John Surface.
Yes.
Bruce Peters. Yes.
Yes.
Supervisor Maggard. I think you were muted, sir. Supervisor Maggard?
Oh, yes. Yes, I'm sorry.
Okay.
I didn't hear what you said.
Dr. Canson?
Yes.
Sheriff Youngblood?
Yes.
Kathy Prout?
Yes.
Dr. Lyon?
Yes.
And Leslie Wilmer?
Yes.
Passes all ayes.
Very good. Thank you, Mr. Ferris. Next is item number 7, which is public comments. We offer an opportunity whenever we meet for the public to talk to us about any matters that are on our agenda, and we would welcome now that opportunity. Are there any members of the public on this virtual meeting that would like to make comment to us this afternoon? Mr. Ferris, do you see any hands going up?
I do not.
Okay, very good. Thank you. We've offered that opportunity, so we will move on now. There are no public requests under item 8. There are no items of unfinished business under 9. We've covered 10 under our consent. So next we have a manager's report.
Yes, sir. I'm ready to proceed.
Okay, please go ahead, Mr. Ferris.
Thank you. You know, Supervisor Maggard, the last meeting, you made some very profound comments towards the end of the meeting regarding, you know, not knowing where we were going to be with COVID-19. And I found that looking back now, hindsight, those were very profound words. I'm going to see if I can do this time, share my screen. You all should be seeing PowerPoint.
Yes, we can see it.
Okay, so in the months since we met last, November, December especially, we saw significant changes that occurred in our system. The following issues were being felt by all of our stakeholders: increase in call volume, increase in transport volumes and overloaded hospitals, increase in COVID-19 patients, of course, increased number of ambulances that needed to be decontaminated following COVID-19 exposures. That number increased 322% in November. So taking a look at this screenshot of the public health dashboard for this is the day that we met last. You see it's highlighted, it's very dark right here, the 12th of November. That was the day you made those comments about not knowing what was going to happen and where we were going to be. And you see what happened within just a short period of time after that day. By November 30th, we went from a case count of roughly 320 averaging a day to 895 by the end of November. By December 9th, we were at 1,479. We peaked that day. And then January 4th, we were at 1,364. So we see the spike here. And if you look at these dates, pretty much following Thanksgiving and then following Christmas is when we see the highest spikes occurred. When that's going on, everybody's being affected in our system. Our ambulance providers' ability to offload patients was drastically affected with the increase of those APOT scores that we've talked so much about. In the month of December, we saw offload times of between 1 and 2 hours go to increase by 78%. Between 2 and 3 hours, it increased by 267%. And then offload times greater than 3 hours increased by 354%. So these were huge numbers. At the same time, we had hospitals. We were seeing massive increases in COVID patients rising rapidly. And on November 12th, the last time we met, hospitals had reported 15 COVID-confirmed ICU patients, 61 hospitalized COVID-confirmed patients. By December 31st, we saw 78 in the ICU with 372 hospitalized throughout our system. And on January 20th, we saw that peak at 87 in the ICUs and 405 hospital COVID-confirmed patients. So what did we do? The steps that EMS took to kind of help combat what was happening in the field. So in response to these issues, first we implemented and mandated an ambulance patient offload policy. This was that policy that allows ambulance providers to staff hospitals with their own staff and empty gurneys, and allows incoming ambulances to hand off those patients to the ambulance staff waiting there, so that that crew can go back out on the road and respond accordingly. This played a huge factor in us getting us through this last peak in COVID-19. I'm going to show you some interesting numbers in a while, but we temporarily waived response time compliance because this was the call volumes and the APOC scores were such that we just could not hold to compliance. BLS percentages were waived, so that released more ambulances to respond to critical patients than would have normally been available. Next, we updated our assess and refer policy. This policy is what allows EMTs and paramedics to get on scene, assess a patient, and then make a determination whether, based on a specific criteria, this patient warranted transport to a hospital. This policy was put in place because our hospitals were already overflowing, and we were trying to cut down on any unnecessary transports to hospitals. And to help with this, we created and implemented, I had 10,000 of these cards printed up and handed out to all of our field providers, so that when they did not transport somebody, they handed them a card which gave them instructions, and it gave them ideas of how to get help if they needed it. It gave them contact information, and it was available in English and Spanish. We waived mandatory ambulance responses to some lower acuity calls. So if the ambulance levels were reaching critically low levels in the metro field, in the metro area, and these low acuity calls were coming in, we waived their responsibility to respond to those. To assist with those, we brought in Pro Safety and Rescue, which is an EMS, was already an EMS provider, approved provider, to do standbys, and they have been first responding to these calls when the ambulances cannot respond. Next, we developed a surge plan, and the surge plan basically brought together all of the different pieces that I just talked to you about, along with a few others that we implemented when the system got so busy that we had to make these drastic changes. And basically there's 5 levels to the surge plan. Level 0 is just monitoring. It's basically if we've got up to 5% increase in call volume, where we're just watching and surveilling the system. Level 1 is if we had a sustained increase in call volume between 5 and 11%, significant units that were out in need of decontamination, increase in patient offload times, and if there was an impact of staffing, we had to worry about our field crews and their staffing levels due to COVID-19 as well. So in this level, this is where we implemented the assess and refer policy, the patient offload policy. We rewrote and updated our against medical advice policy, which allowed EMTs to assess and effectively accept a dry run from a patient without having a paramedic there. The next level is level 2, which is yellow. This is the level that we actually went into at the time that this was implemented, and we currently are still there at this moment. This level, we had a sustained surge of greater than between 12 and 25% in call volume, significant increase in decontamination of ambulances. We had increase in patient offload much greater than 30%. And we never did, thank goodness, staffing levels, while they did have a small effect on some of our providers, they never affected us to the point of 25%, which was listed here. But in this level, you see where we activated our low-level alpha calls. Those are those low-level non-acute calls. I unrestricted our mutual aid so that the closest ambulance to a critical call would get the call no matter what the boundary line was for the exclusive operating area. Ambulance dispatch agencies were instructed that if they could not respond to those alpha calls, they were to make contact with the caller and inform them of the situation and they would not be responding. We also mandated the straight to triage policy, and then again, we mandated that assess and refer policy. The next level, which we did not get to, thank goodness, and hopefully never will, is level 3, the red level. This is 26 to 49% surge increase in call volume, continued increase in decontamination of units, 45% or greater of offload times, and 35% of staff issues. We would totally wipe out alpha calls. We would also be looking at dropping responses to even higher level of calls if we had to go to red. And then the last level is black. Black is if we basically cannot respond anymore, 50 to 100% increase in calls, another drastic increase in decontaminations, 55% increase in offload times, extreme staffing reductions. This is actually a dispatch policy that has been in effect for years. It's called Code Z. And if we ever get to Code Z, we will be advising 911 callers that we cannot respond and that they are to find their way to, usually we're going to tell them to go to a local high school football field, and those will be turned into field treatment sites. And we will begin to send ambulances and first responders to those sites to start treating patients. Hopefully that will never happen also. So in January, we saw a downturn in our system. We actually started to see positive effects from the changes that we made. Here you see from October through January, the surge that occurred. We had in December 11,050 calls. The raw call data for January was 10,648. Now we see Pro Safety's effect on the system. They ran 141 of those calls, and then we surged 268. So that equated to a 4% reduction in calls for our ambulance providers. That doesn't sound like much, but it is a huge number when you're dealing with so many calls a day. Transport, same thing. We have our assess and refer policy that we assessed and did not transport 225 patients in the month of January, which was a great relief to the ambulance providers. That was a 3.82, so basically a 4% effect again. Deconning of units, you see that rose 322% in December, from 200 in November to 844 in December. January just saw a slight uptick, and ever since the end of January, it's been on a downward slope of the decon, and they're back down to somewhere around 20 a day. At the highest, we were seeing 50 or more a day ambulances that needed to be deconned. Our APOT scores we see here, we talked about those in our surge plan. In December, we saw the APOT numbers for the 60 to 120 jump 177, basically 178%. Now, this is the patient handoff for that offload policy. So in January, we saw 44 different occasions where patients were handed off to ambulance staff that were staffing the hospital. Again, the 2 to 3 hour offload, we see that jumped in December 367%. And then in January, we saw that 29 patients were offloaded to ambulance staff at the hospitals. And then the over greater than 3 hours, we saw that 19 of those, that was up 454%. And now we see that in January, 19 of those patients were handed off. So we continue to work on vaccinations. We are of course part of public health, and we work very closely with them. We've tirelessly been delivering vaccines to medical facilities throughout the county. We've had hospitals requesting vials of vaccine be delivered at very odd hours of the day and night and morning. Additionally, we've been an integral part in the vaccination clinic at the fairgrounds. We provide medical supervision at this point for the people being vaccinated. So as they're vaccinated, they have to go sit for 15 minutes or so, and it's my staff that sit and watch them to make sure they don't have any adverse reactions. Moving forward, I'm scheduling meetings with field providers beginning next week to start talking about the future and what Kern County EMS is going to look like. We're going to take what we have learned from COVID-19 and apply it to how we operate in the future. It's my goal to figure out the best way, the most appropriate way for our EMS system to operate, to provide care for the people of Kern County. And I think that we need to take those lessons we've learned and apply those to our day-to-day life, assuming we get back to a quasi-normal life without COVID anytime soon. That concludes my report, and I'm available to answer any questions.
Thank you, Mr. Ferris. I suspect possible some of my colleagues on the board here will want to ask some questions. So let's open it up to you guys first. You guys have any questions, Mr. Ferris, about the report?
Hi, this is Earl Canson. Just a quick question about the stage yellow that we are in. How long are we in that stage? Is it a determined time, or is it just when the numbers change, that's when the stage changes?
We're watching the numbers very carefully. Right now, the numbers are trending down, and it's very hopeful. We want to be very careful that we don't knee-jerk and come out of this too soon. We hear that, with the different variances of the virus that are out there now, we could see another peak. We just had Super Bowl Sunday. So we're watching the numbers very carefully. We will come out of it once the numbers drop and appear to be maintaining at the lower levels, then we will absolutely come out. And that's the part of the future that I'm looking at, as to what the lower levels will look like in the future.
Thank you.
Very good question. Anybody else have any questions you'd like to ask?
Mr. Chair.
Yes, Sheriff, go ahead.
No, I'm just going to make a motion to receive and file.
Oh, thank you. So we have a motion from Sheriff Youngblood. Let's go ahead and get a second. Then I have a couple of questions I'd like to ask. Is there a second to the motion?
I'll second Leslie Wilmer.
Thank you. Before we vote, I just want to ask a couple of things. Mr. Ferris, how effective would you say, clearly it was effective to have a different response to low acuity calls for ambulance service, but is there anything that you would tweak about how we've done it? Did we learn any lessons that we should consider, when the next surge comes, if it does?
Basically, sir, to answer your question, I think what we put into place worked extremely well. We had a very, very low percentage of issues with the policies that we put in place. Most of the people who were contacted and told that ambulances were not responding to them took it very well and understood. And because those calls, those low acuity calls, are extremely low acuity. Under normal circumstances, we would have transported that stub toe or that, tummy ache or whatever it was. And in these cases, we simply said, we can't do that. And they understood. And in some cases, we instructed them to go to urgent cares. They did. They followed that instruction. And it worked extremely well, extremely well. So I think that in the event that we have another spike, or that we have another issue where we need to implement something like this, that it would be implemented pretty much the same way that it was this time.
Very good. Thank you. Okay, I didn't ask the public. Are there any members of the public in attendance that would like to ask any questions of Mr. Ferris about that report? Anybody indicating that, Mr. Ferris?
No, sir.
Okay.
Mr. Chair, Mr. Chair, it's Bruce, if I can make a comment.
Please do.
You read my mind when you asked that question about the policy, and I think it's a really good policy. I think it's way overdue. I think it has merit to be used beyond this pandemic, and I'm hoping that the powers that be would see that continue beyond when we get through with this pandemic. It really does help the hospitals. I'm certain it helps the ambulance companies, and I would urge that we continue this policy going forward.
Yeah, thank you. I know that's a conversation we're going to have, and I appreciate that. there will be a few good things when the dust settles on COVID, and some of them will be how we run more efficiently, because it's been remarkable how well people have done. Mr. Surface, do you have a comment?
Yeah, thank you, Chairman Maggard. So, back in November, to give you an idea of how important this policy is, in November, we had 1,500 calls that would have gone into the bucket of calls that Jeff was describing. 900 of those do not end up in transport. So we're running either lights and sirens, or we're running out to a house to check on somebody, and we're not even taking them to the hospital. They're just asking for somebody to come and check on them. No intent to go to the hospital at all. So those are the kind of calls that we can eliminate. The growth of our system, or the maturity of our system as we move past COVID, is going to be to address that, right? Address these people that don't really need to go. Help doctors understand that just because they've started treatment doesn't mean they have to call for an ambulance to transport to the hospital. There's a lot of moving parts to this. I think it's been successful. I think there's a couple of small risks that need to be, the policy needs to be tweaked a little bit. But I would tell you that back in July, you may remember, we had to call for help from outside the county. And we had to call in 2 strike teams for a weekend. Had we had this policy in place in July, we would not have called in strike teams to run our calls for us, right? The effect on the morale of our employees has been tremendous, at least realizing that somebody else realizes that they're getting beat up. And so this has been a good policy. We certainly endorse looking at it in the future, finding a way to bring it into play when other, when the flu's going to come back next year. It may not be like we have now, but every year we have some major flu event. So I'm glad that the department was able to pull it off. Thank you to Dr. Lyon and to Jeff and everybody that was involved in pulling it together. It was a lot of moving parts in the beginning, but certainly it was a good thing for our community.
Yes, indeed. It had similar implications on the fire department. We had to reprioritize the kinds of calls that the fire department responds to, and it just calls for a wholesale review of that when the dust settles on this. Mr. Ferris, I'm not certain if you responded that are there any members of the public that wanted to make a question or comment?
Not that I see, sir.
Okay, then could you please poll the board with the motion made by Sheriff Youngblood, and I think it was seconded by Mr. Peters. Oh, it was by Leslie, sorry, Leslie.
Certainly, sir. John Surface.
Yes.
Bruce Peters.
Yes.
Supervisor Maggard.
Yes.
Dr. Kansen.
Yes.
Sheriff Youngblood.
Yes.
Kathy Prout.
Yes.
Dr. Lyon.
Yes.
And Leslie Wilmer.
Yes.
Passes all ayes.
Thank you, sir. The next thing we have on our agenda is an opportunity for board members to make any announcements or reports. Colleagues, do you have anything you'd like to say?
Chairman Maggard, John Surface. I probably wouldn't get to sleep tonight if I didn't mention the anniversary from yesterday. Yesterday, Hall Amos was able to celebrate 50 years in business. It's kind of a downer that the boss isn't here with us because he would have thrown a heck of a party, but nonetheless, he trained us well and he built a good company, but 50 years is quite a mark in the public ambulance industry. So I just wanted to share that.
Thank you, John, for mentioning that. You beat me to the punch. I have a couple of things to talk about when it's my turn, but I'll do that in a moment. But thank you for mentioning that. Any other members of the MCAB board like to make comment to us this afternoon? I have a couple things to thank you. Then I have a couple things to report. First of all, about the 50th anniversary, I reached out to Levon earlier, and it is a bittersweet moment. I had an opportunity to serve with Harvey Hall as my colleague when I was on the city council. He would have enjoyed this, and you're right, it would have been a party. It would have been fun to see how he would have dressed up and what color suit he would have worn, and I miss those things about him. But our community's been well served by you guys, so congratulations on your 50th anniversary. Next, I wanted to just introduce to you, I know you already know her, but is Bryn Kerrigan still on this call?
I am.
Matt Constantine has long planned for his retirement to come to fruition at this point. The board has known about that, and we have been planning for and preparing for that for some time. It's not because COVID got the best of him and he just got tired and decided to walk out the door. He's been planning this for a long, long time. So we have very carefully and prudently been planning how we would have a plan of succession in the public health department. And we were thrilled that Bryn Kerrigan was available to us and has demonstrated under fire her ability to carry all the responsibility that this comes with it. So the Board of Supervisors has named Bryn Kerrigan as the new Director of Public Health. But Matt is working alongside of her through March. But I just want to introduce to you that transition is underway and Bryn is here. And Bryn, I just want to congratulate you in front of everyone for the success you've had on this appointment. And do you want to say anything to us before we go on to the next issue?
I do. Thank you. I'm really excited to be here and in this role. I feel like I've learned a lot working alongside Matt for the last 8.5 years and being a part of the EMS system for the past at least 4 years, being Jeff's supervisor. And the EMS system is very complex, but it is very interesting. And I'm really excited to endeavor on this new opportunity. So thank you.
Very good, Brandon. Last, I wanted to speak to COVID for just a moment. There are a couple of issues I wanted to mention to us, just so we're kind of all on the same page about this. First of all, it is remarkable the amount of cooperation and innovation and dedication, the sacrifices that have been made by all of our hospitals, by all of our emergency responders, by the health department, by the MCAB staff and support staff. It has been a remarkable thing to watch how effectively they have responded. I think I alluded last time to this meeting that occurs on Wednesday afternoons that has all the hospital administrators in it, and it's just these aren't just words I'm throwing around loosely. It is remarkable to watch how effectively they have managed and dealt with the concerns about what kind of surgery would have. Praise God in heaven, we never ran out of ICU space. We had hospital capacity the whole time. We found a way for the ambulances and fire trucks to be able to respond. Even the sheriff's department, they're walking into unknown territory all the time. So it's just a remarkable expression of the dedication that people have to make our community a safe place. And I just want to congratulate all of them. This could have been way, way worse, and it's not because of the remarkable work of everybody that's involved. And forgive me if I have missed someone's name, as I've done this off the cuff this afternoon. The next big issue we have, or as a former colleague of mine used to say, the next biggest wolf that's closest to the shed is the issue of vaccinations. We have now developed the ability to deliver to patients, to constituents, about 40,000 shots per week. So we could pump out this vaccination if it were available to us. But we're only receiving from the state between 6,000 and 8,000 shots a week. There are some regional providers that have other resources, Adventist, Dignity, some places like that, Kaiser. But bottom line is we have a vast shortage in that. And I don't know when the supply chain will catch up. But when it does catch up, we'll be able to very quickly push this serum out into the community. One of and as some of you represent on this board, you represent people who are affected by what I'm about to talk about. But others of us, represent in our various roles in our community. There are many people who want this shot and they can't get it yet. So we have had to make the miserable decision about how we prioritize who gets what. And the reality is that the vast majority of people who die from COVID are greater than 65 years of age. And the people that contract the disease that are younger than that have a very, very much more likely positive outcome. So we have made the agonizing decision to persevere and inoculate as many of the 65 plus population as want and can receive the vaccination. And that means that other very deserving people, like even some first responders, even teachers, even people in all kinds of different roles in our community, they're having to wait. And it's a terrible decision to have to make, but we're trying to save the most lives possible, and that's what's going on behind that. And as soon as the supply chain catches up, we are committed and have the capability of pushing that vaccine out into the community. So if anybody asks you, that's where we are with it. And that's kind of what our circumstance is. But I want to thank you guys for just being a steady hand in this, and everybody else that's involved. You know, Dr. Line is rather quiet in this group, but he plays a significant role. And I want to personally thank him for his help in us getting us through this, because at times it is his signature alone that allows us to move forward. And we have moved forward with lightning speed about many, many things. And Chris, I just want to thank you for your help with doing that for us. Okay, do any other board members want to say anything else? Okay, then thank you. I have an announcement. Our next regularly scheduled meeting is Thursday, May 13th, 4 p.m. Almost assuredly, we'll be doing it remotely like we are now, but we will let you know about that if that changes. The deadline to submit information for public requests for that meeting is Thursday, April 29, 5 p.m. To be sent to the Kern County EMS Program Manager. So without any other matters before us, I want to thank you all for being here today and for your commitment to us keeping our community a safe place. And I would call for a motion to adjourn.
So moved.
Thank you. I was afraid we'd have to stay here longer for a minute. So good. Okay, thanks everyone. Without objection, so ordered. We'll see you next time. Stay safe.
Thank you, everybody.
Okay, bye-bye.
Thank you. Bye.